Hi, everybody, and welcome to today's webinar on mental health at the front line of the pandemic, stress management in the health workforce. This is part of our webinar series called Health Management in Action, Fostering Health Systems Resilience. This is an Emma webinar, and it's number 6, I believe, in our series. And these webinars are co-funded by the European Union, so we thank them for that support. I'm George Valiotis, I'm the Executive Director here at Emma. So to tell you briefly about Emma before we get started, our vision is excellent health management for a healthy Europe. The way we do that is by supporting the spread of knowledge on effective health management, exactly like this webinar is doing now. And we always live our values of excellence, quality, inclusiveness, relevance, and respect. And I trust you'll feel those values being lived in this webinar and any other work you see from Emma. Some other things to describe us is that we're the only membership organization in Europe that brings together the full diversity of the health ecosystem. So that means anyone from hospitals to decision-making to community care settings. We're a recognized and respected amplifier of best practices in the evolution of health management. And I think you might get a hint of some of that today. And we provide an environment where evidence, challenge, and experience are valued, and complex debates on current topics can take place. And on that note, I encourage you to really engage with the webinar today. You'll hear from great speakers, and we really invite your questions and your challenges. So if you're not already an Emma member, this is a prompt for you to please join us. You can get more information on our website. If you just go to emma.org, you'll see a lot of information there about becoming a member. So do go and check that out. This series is Health Management in Action, Fostering Health Systems Resilience. We discuss topics like health management that are critical to health management, like improving health system preparedness and response. And we've had 5 in the series so far of different topics. To make sure the webinar flows well, we'd ask you to do all the usual things. Hopefully we're well practiced at. Keep your microphone on mute. Feel free to chat, put your questions in the chat box, but also you can put your hand up and we can come to you to ask it live at the end of the webinar. We do record the webinar and everything goes on our website. So if you wanted to see the slides, a recording or any other information, usually within 24 hours of the webinar, we have these up on our site. And we do live tweet. If you are on Twitter, we'd love to hear from you. Find us on Emma Info. So in terms of today, I'm giving you right now the welcome and introduction. And then we have 2 speakers. We'll have a presentation on the Magnet4Europe study, which will be delivered by Dr. Walter Sermeus. And then immediately following that for 10 minutes, we'll have a presentation on the case of hospital Bremerhaven-Reinkenheide by Mr. Patrick Focken. Patrick, I should have practiced that pronunciation before we started. I think I did okay.
It works well.
Oh, good, thank you. And then we have time for Q&A, which we really encourage you to get engaged in that, as I said. So just to let you know a bit more about our 2 speakers, as I've just mentioned. First, we hear from Dr. Walter Sermeus. He's a full professor at KU Leuven, who's been a member of Emma for a long time. He's in the Institute for Healthcare Policy, Program Director of the Master of Healthcare Management and Policy. He's the head of KU Leuven WHO CC on Human Resources for Health Research and Policy here in Belgium. And then we'll follow by Mr. Patrick Focken, who's the Magnet Coordinator at Hospital Bremerhaven. Here we go again, Bremerhaven-Reinkenheide in Germany. Although Patrick, you're currently not in Germany, but you're in the US at the moment. So those are our speakers. Really a privilege to have you both with us. Walter, I'm going to hand over to you now to start us off with your presentation. Thanks for joining us.
Thanks, George. Thanks for the nice words, and thanks also for the invitation for this webinar.
It's a pleasure. If you want to put your slide, yeah, great. We can see your slides. I'll leave it to you.
Okay, can you see and hear me?
Yes, we can.
Yeah. Okay, so I will talk about the Magnet4Europe study, and so how we are tackling mental health, not only at the front line of the pandemic, but more in general, as it become more important, I think, for health workforce. And so I share with you a few pictures we all know from the previous year and months. And you see 2 types of pictures. So one picture is people that are really exhausted in fighting against the pandemic during many months continuously. That's one picture you see. And the other picture you see right in the corner, it means that a lot of these people are also becoming sick or at home. And what we see at the same time, we see a big shortage at this moment in time on workforce. And the two things together, people really having to recover from that pandemic, and at the same time, we are confronted with a shortage that's not only COVID related, but will take longer, is a big challenge, I think, for the healthcare for the next decade. Is my expectation. So what I would like to do is to present you the perspective of today. So the perspective of today is the Magnet4Europe study. It is funded by the European Union. It was running from the 1st of January 2020, and it will run until the 31st of December in 2023. So it means for 4 years. The call was mental health in the workplace, and it means that already in 2019 or 2018, when we were preparing for this call, this is already a right important topic to deal with mental health in the workplace. And so it was a quite competitive call. So we had about 120 different submissions, and five projects were selected. And we are the only one that was really focusing on healthcare. And so the main focus is on trying to understand and to improve mental health and well-being for doctors and nurses in hospitals. And how we are doing that is not to give some individual stress coping mechanisms, but by really changing the working environment of hospitals, what we think is key for this problem. So I will tell you about the problem and how we are trying to solve this problem during the webinar. So just to give you some overall idea, we try to work with the best hospitals in Europe and best universities in Europe. So Leuven is coordinating this project together with the University of Pennsylvania, and the person involved there, so it's my co-director for the project, is Dr. Linda Aiken. But we have good teams in many countries. In a few European countries, it means with the Technical University of Berlin, with University College Cork, with King's College in London, Karolinska Institute, University of Southampton, the School of Hygiene and Tropical Medicine in the UK, and one hospital, it was the USA, it's the Antwerp University Hospital, who had already some magnet designation, and Maplis is a software company in helping us with collecting some data. More important for the study is that we are doing the study in hospitals. And so we're doing this in 6 countries. It's in Belgium, Germany, Sweden, Norway, the UK, and Ireland. And at this moment in time, 65 hospitals are involved in the study. What means that it's a large study to do. One of the elements, and I come to that in a minute, is that we are twinning or pairing each of these European hospitals with a US hospital who had some magnet designation in the past. So it means that every European hospital has a kind of expert coach in coaching through the intervention. And I think it's an important feature, and Patrick will talk about that relationship also in his talk, what is a quite essential characteristic of the program. If you want to follow us, we have a website, magnet4europe.eu. So please visit the website, and there is a lot of information in the website on the project. So what is the intervention? So the intervention is organizationally designed. So we think that when we are working on mental health and well-being, you can focus on the consequences. So it means that a lot of these workplaces are not the best workplaces, and it means you can learn people how to cope with that. But the better way, and we think this is the preferred way, is to redesign that working environment and make that working environment better, so that people are better supported to do their job. And the job they really want to do is taking care of patients. That's the case for nurses, and that's the case for physicians. And so there's one program in the States, it's called the Magnet program, who is implementing these principles and is really reshaping this working environment so that people, nurses and doctors, really can do their main primary job and are supported to take care of their patients. So that's the intervention. And so we worked with ANCC, the American Nursing Credential Center, who allowed us to use their blueprint in really working with these Magnet principles. What we do is a gap analysis, see what are the characteristics of these hospitals, and are they meeting the criteria that is defined in this Magnet program. And we set up for each hospital in co-design with these hospitals an action plan. And so these hospitals are guiding through that action plan by an established Magnet hospital that has some experience. So I told you we have more than 60 US hospitals involved in guiding these European hospitals. Altogether, they represent about 850 years of expertise in working in this Magnet environment, what is quite interesting. Just to give you on the right side the picture, what are the elements? The elements are giving some empowerment to the clinical staff. So it means that you are can engage for your patients in a much more global way. Second thing, we are working on the leadership. We are working on innovation and on evidence-based practice, and we are working on what kind of best practice we can share and how we can work together. And the focus is to really look to the outcomes and try to improve the outcomes. So that's the idea. So redesigning, so it's a tailored program for each of these hospitals. It's in working together with an established US hospital. We have some experience in it. We bring these hospitals together from time to time in what we call learning collaboratives. They are monthly by Zoom, but we encourage also to have these visits. So it means that US hospitals are visiting our European sites, and our European sites at the same time are visiting our American sites. We just had in live learning collaboratives in the US, and also Patrick is at the moment in the US visiting his twin hospital of the hospital that is twinning with the hospital of Bremerhaven. We think it's important to have enough critical mass of hospitals in these countries so that they can learn from each other, that they can ask questions, that they can discuss things. And at the same time, we do some evaluations. It means that every year we are serving these nurses and doctors. We have some focus groups, we have talks, interviews with these people. We try to analyze the full process. And what we also do at the same time, we are making a kind of cost-effective analysis of this of the whole process. The way we have been designing it is in a kind of cluster randomized controlled trial in which we are following two cohorts of hospitals that started at different time levels, and so we can see how they develop and how they grow. So what I want to do is to give you a few of these examples so that you know what is coming out of the study that is quite relevant for COVID, and at the same time some of our main findings or lessons out of the study. Just to give you some idea about where we are. So this is so you see the green line over here, and the other lines are the waves of COVID during the 2020-21, because we started the project right before COVID. It was not meant to be in COVID, of course. So, but we were quite happy that no hospital dropped out because they think it's important. And we had our data collection between October 22 and June 21. So I will present some data from that time period. And it's, as you know, as you see also in the slides, it's in the middle of the COVID pandemic. So you have some idea about these results. Altogether, we interviewed about 11,000 nurses, 11,000 people. It's a little bit more than 9,000 nurses and more than 2,000 physicians. So these are some ideas. It gives already some idea about some baseline findings. So we find high levels of burnout. It means what we call high burnout, high emotional exhaustion for one fourth of the workforce, 25% for nurses, 23% of our physicians. There are high levels of job dissatisfaction. There is even a high intent to leave the hospital. Mainly people look at other jobs, trying to do other things. We see a lot of symptoms of depression feeling anxious. There is some report of overall fair or poor overall health. And what we mainly see is that people are saying we are in a very stressful job that doesn't leave us enough time for our personal and our family life. And I think these are important findings. It's showing that in that pandemic, the workforce is really under stress. And so we see the same kind of figures for nurses and physicians. So we also asked these nurses and doctors, what do you want us to do? What you want your hospitals to do? And what is the main thing that can help you? In all cases, it's the case for nurses and for doctors, what they see is improved nurse staffing levels. It's the first thing that they want. They want reduce bureaucracy and red tape. So all the procedures that are there, they think sometimes it's really a pain in the ass in getting things done, and it's mainly felt that way by doctors. They want that the clinical documentation burden should be reduced. So they say that they have too much time to fill out papers and they want to spend more time with their patients. And also, of course, and it improves physician staffing levels are also mentioned by these doctors, less by the nurses. But nurse staffing levels are mentioned as a main priority, both by nurses and doctors. What they thought was not so interesting to do, and I know that a lot of hospitals are focusing on this, is reduce overtime, create some time and places for meditation and reflection, or provide resilience training. They are saying, yes, it would be fine to help us and to give us a little bit more time and to help give us time to reflect and to cope and so on. But the most important thing, I think that's what we learn from the nurses and the doctors, is to go to the cause of the stress. So it's really changing the way we are working, changing the working environment, see that there is enough people, see that we can do our job. That's the main message, I think. And so that's why we focus on reorganizational design and not on coping with these stressors at the workplace. And just to give you some idea about what we mean by this workplace design. So one of the main instruments we are using is what it's called work environment scale. So it's looking to enough staff. It's looking to, is there some perception of quality? What is the management and leadership support? If you have a question as a nurse or a doctor, in which way you feel supported, do these nurses and physicians go well along, and do they find themselves? And do these nurses and doctors have something to say? So when they have a problem, can they say it to their management? Do they get them their support? If they have an interesting idea, can they put it in place? So these are the most important things. And based on these 5 elements, we divided the work environment in what we call poor. So it means that these factors are not there, or medium, it means mixed, or good working environments. And these are the data for nurses. What we see is when the working environment is good, you see better job satisfaction. It's more than 10% higher. We see lower burnout rates, going from 28% in these poor environments to 17% in these better environments, and we see much lower intent to leave. So it's almost half of intent to leave in the better environments than in the worse environments. And we see, in fact, same figures for doctors. So we see also for doctors, these job satisfaction are going up, even much more pronounced for burnout and even more pronounced for intention to leave. And that gives us the idea that, of course, what we see is that COVID has some real impact on the stress of our frontline staff. But at the same time, we think that some hospitals were better prepared for COVID than other hospitals because they focused and supported much more that working environment. So to give a few lessons, what we learned so far is that the cause of burnout and other mental health issues is mainly situated in the organization of work. That's what we know. Burnout is mainly work related. Of course, there might be some other factors also in the personal life, but it's very strongly related to the work life. What we see is that there are 2 types of interventions. So you can focus on individual interventions, and it's more on coping with the stress, or you can do an organizational intervention in which you try to redesign the working environment and prevent stress. And what we see is that certainly these doctors and nurses have a preference in working on the cause rather than on the symptoms. So this is an important thing. What we see is that COVID-19, it probably worsened mental health and well-being, but we think that some hospitals are much better prepared because they focus in creating good working conditions. And at the same time, we think that improving that working environment will be important for the future to attract and retain clinicians, doctors, and nurses. So it's an important focus. The Magnet model we are using this project can help. So this is one of the things we try to do, is to really show if it has an effect, and we will try to evaluate this during the project. And the project is little about half, I think. So the project is ending by the end of 23, so a little bit more than 1 year to go. So this is a little bit kind of the context and the presentation of the project. I think we can go now a little bit more in detail with a case that Patrick can present. So he's in a good position now. So he's the Magnet coordinator in the hospital Bremerhaven in Germany. And at this moment in time, he's spending his time now in Ohio State University, James Cancer Center at the same moment, early in the morning there. So it would be good to see some example how this intervention is really working and how they are really putting it in place. So thank you, and I give over the floor back to George.
Thank you, Walter. That was fascinating. There was a lot of information in there. And what I'd encourage the audience is, if you have any questions, I can see already there's a few questions in the chat box. And if you have any others, please feel free to type them in. Like I said, afterwards, we can come back to them in person as well. You can ask them live, but you can get started there if you want to make sure you remember what you want to ask. So Walter, you've set us up well for some examples from Patrick. So Patrick, I invite you to take over.
Yeah, so thank you for the transition. Good morning is here in Ohio, because now it's 7:50, and good afternoon to Europe. Thanks for the invitation, and I want to show you two practical examples. What does it mean to work on the Magnet4Europe study? So I will share my screen. Okay, before I start, I will give a short overview about our hospital. It's the Klinikum Bremerhaven-Reinkenheide. It's a community hospital in the north of Germany, near the Northern Sea. We have about 800 beds and 1,900 nurses and physicians. And what is specialized to us is we have telemedicine for research journeys to the Arctic and the Antarctic. And we are working on the Magnet4Europe study since 2020. So that you have an insight how it exactly works. At the beginning of the study, we have to do a gap analysis, and to reach sometimes the recognition, magnet recognition, you have to fulfill 76 requirements, which are regarding to the magnet model, which Walter showed in his presentation. And we made this gap analysis at the beginning of the study, and from this gap we made projects that are necessary to change our work environment. And I think regarding to the challenge at the moment because of COVID, I think it's really important to give the nurses as well the physicians the empowerment and the engagement to change the work environment. And so for that, I want to give you two examples. The first example is a so-called professional practice model. You see on the right side the magnet model, and the requirements. One requirement is that you have a professional practice model. And what means that? The definition is it's a conceptual framework for nurses, nursing care. Sorry. and interprofessional patient care that depicts how nurses practice, collaborate, communicate, and develop professional to provide the highest quality care. So as we start with this project, we founded a working group in April last year, and we had about 6 meetings, and we want to find another way to engage the nurses. So we chose a bottom up approach, and we made about 100 interviews with nurses with the question, what does nursing means to you? And we collected all this data. So in the working group were nurses, for example, there were social workers, there were also physicians, there were nursing teachers, and they went all over the wards, the departments, into the school, and asked everybody, what does nursing means to you? And all the results of our interviews we collected and analyzed this. We used for that inductive category formation, and then we developed the first draft, showed it to the ward again, and then we started with the rollout. And that's our result of this professional practice model. We try to summarize all the answers, and we have here an outer circle and an inner circle, and the outer circle are more describe the competencies of nursing as the nurses thinking about nursing, so communication, professionality, self-care, and individuality. And the inner circle means what nursing means to the nurses. So nursing is meaningful, empathetic, autonomous. Nursing is also responsible and thoughtful. And what was really important for all the nurses that we put the human care into the center, and that's why we put this central sentence, human being at the center of our care, in the middle of our model. So at the moment we are on the rollout of this model. We printed it on posters and framed it and hanged it out on the different wards. We also use it for the quality department and the quality management in our house. For example, we have morbidity and mortality conferences, and always when we find a conflict or something doesn't work, we use this model to find the competency, for example, what didn't work. So maybe it's a communication problem, for example. I think with this approach to let the nurses develop their own professional practice model, we set a high signal of self-empowerment because of the bottom-up and approach, and this is an important milestone on our Magnet journey. Another project which is at the moment running is the so-called mentoring program. So it's regarded to the Magnet component and transformational leadership, and the definition of mentoring is a professional partnership between a mentor and a mentee to accompany new colleagues from the beginning on the way into a new area of responsibility in order to retain them in the long term. And that's a really important thing, because we have to retain our colleagues, nurses as well as physicians. And we have a high turning over rate, not only in Germany, also in Europe, also in the United States. And I think it's very important to improve the work environment to retain all the colleagues. And so we developed a new program. Here we founded a working group in April last year, and this working group had about 8 meetings, and at the beginning they made a literature review, a brainstorming, and a huge exchange with a twinning partner. So I'm at the moment in Ohio, Columbus, as George and Walter mentioned, and we getting really inspiring insight yesterday on our hospital, and to get a feeling for that, what mentoring means and what a magnet work environment means. And all these informations in our exchange we used to create a first concept. And this concept we tested on a geriatric ward. It was tested by physicians. And after a period of about 6 or 8, 2 or 3 months, we make a revision of this concept, and then we present it to the management. And after the concept revision, we tested it again on an emergency unit, and there it was tested by nurses. And now our mentoring program is finished, and now we start with the rollout all over the hospital. And not only the mentoring program is not only used by the physicians and the nurses, we also use it for the administration department, for the IT department, the technical department. So the mentoring program means mentoring for all the staff in a hospital. And we already had small feedback, and on the picture you see 2 physicians from the geriatric ward, and Dr. Verena Flemke, who is very motivated to work on Magnet, said about this mentoring program. Mentoring requires a relatively small investment of time, but it brings great benefits for the mentee and also for the hospital. This made implementation possible even at times when things were very busy. And I think that's very important, because we developed this program in the last 2 years. So we developed the program during the COVID pandemic, and we created a program that works. And as the mentee, Greta Gerhold, she's a physician, said, mentoring provides a common thread, especially in the hustle and hurry of everyday routine. It also provides security should you ever lose track of what you're doing. This means there's always someone to talk to. And I think this bold citation shows how important really this mentoring program is for our physicians. So many of our colleagues will retire in the next years. So many colleagues will, so many new colleagues and employees will come, and we have the challenge to hold them, to reduce the turnover rate, and that's why we started with this project on our Magnet journey. So now at the end, I came to my conclusion, the opportunity to work with the Magnet4Europe study and to implement the Magnet model offers many opportunities to meet the existing challenges we had. The lack of nurses, the lack of physicians, for example, the high workforce on the wards and the departments. And Magnet allows us that nurses and physicians are empowered to improve their own work environment. So we give them the feeling that they can do something by themselves. I think that's a huge important thing on the Magnet4Europe study. And also the exchange with our twinning partner is extremely valuable, because on the one hand, we learn from each other. And on the other hand, we see that the problems are in America or in the other countries are all the same. So we all have the same problems. And I think the network we built up during the Magnet4Europe study, not only with the twinning partner, also with all the other hospitals in Germany, in Belgium, in England, we all get ideas each other, we help each other, we support each other. And I think only together we can force this huge challenges of the pandemic, of the shortage of nurses. And so I'm very proud and glad that we have the opportunity to work on this Magnet4Europe study. But measurable successes is still to emerge. So that's our next step to measure what benefits we have from the mentoring program and the PPM. And so I come to the end, and thanks for listening, and I'm looking forward to your questions.
Thanks very much, Patrick. Also really insightful and interesting detail about this ground up approach and the mentoring process, the one-to-one processes. I noticed that there's already been some questions in the chat. I want to start with Bear. Bear, I see you're in the room. Thanks for joining us. And you're the executive director of the European Specialist Nurses Organization, so I can imagine how this would be of interest to you. Can I hand over to your question? Did you want to speak to your question or add anything else?
Well, first of all, compliments for the event, George. It has never been so crucial to touch these aspects, and also good to see Walter and his dedication on this program. And Patrick is for me new, but I'm doing well on this domain. I have two questions. But it's up to you if you can answer it. For a long time monitoring, it's always a case of adherence of those participants. And despite all the great efforts, we know that, because there was also a publication done yesterday of today of the immense dropout of nurses, also in Germany and Austria. So for Walter, how do you monitor those nurses who are dropping out, or do you try to also get them back? Because this is really the analysis. Why do they leave, or is it also included in your program? Because the magnet, if it's far away, they drop out. But if you stay away with the magnet, you might hold this iron. So it's a good analogy.
Thank you, Barry, for the question. Two elements, I think. There is one element of the intervention itself, so it means the effect of the intervention. And so together with the hospitals, the intention is to monitor these new people coming in and people going out, and have some insights in why people are leaving. So we are measuring intention to leave. You know that intention to leave is not always the best predictor of real intention of real leaving, because there are many other reasons. So it's something what we do. But the second thing what we are doing in the monitoring, and it means that we are measuring, serving these doctors and nurses every year. And so it means that they have an opportunity to have a full registration at the beginning. And it means that we can also follow that person during these 4 years. And so it means that we have some idea about their intentions and how they react, and what is the context. Of course, at the same time, we allow new people that are in the organization also to answer the survey. So we do it both ways. So one element is to go really to the real facts of leaving and staying. That's one thing. And the second thing is monitoring in the survey, what we try to do by some continuous sample.
Great, thanks, Walter. There was a question also from so Bear, I see you have a question for Patrick as well. Did you want to speak to that one?
What we find in our organization is the lack of opportunities for education. You see, we saw, for example, nurses going from the school, going into the ward, work there, but at least quarter didn't come back because of the experiences, and they really want to go back. So we had a lot of nurses who really want to be more educated. So I thought maybe also, is there a question on the on Patrick? I think it's extremely very good that there's a lot of warmness on nurses by the organization, and I really see that there's a lot of great intentions of nurses. But we also see that that nurses also be facilitated in time and money to do education, and not only specific to their domain. You see, my experience was mental health, and I was not very much facilitated when I want to do something very different. So this education can also maybe very, very, very important. But the facilitations to invite to provide them at least 10% of their time or money, that they can engage in top clinical education, but also going abroad for experiences or go to congresses, for example. Is it also included in the activities of your institutes, Mr. Focken?
Yeah, thank you for this question. Indeed, there's one requirement, and we also made a project from it. It's called Nurses as Teachers. And we went all over the wards and asked the nurses who could imagine to teach, for example, nursing students, who can imagine to teach other nurses in different topics. And yeah, we collect them and try to change our education program. And result is, for example, that we have more bedside nurses working on the nursing school, for example. So we can reduce the theory practice gap, for example. And also, as Walter showed in this his presentation, we have to reduce the bureaucracy and the documentation, so that we get more time for the patients and also more time for the education. And we have different things to do to reach this goal, but yeah, indeed, it's included in the Magnet requirements.
Thanks, Patrick. We're almost out of time. I've got a couple of other questions, but while I come to those questions, one of my colleagues is going to put a link up into the evaluation for today. As I say at every webinar, we build these from the community of practice that is this group. So the link is up there now, and it takes 90 seconds, just let us quick feedback. And if you have ideas on additional questions or other things you'd like us to discuss, for example, has this webinar made you think of other things that you want to hear more about? Let us know in the survey. My question for you, Walter and Patrick, is how have you, and actually this is to Dr. Johnson's question that was in the chat as well, around really building trust and getting people to build time for this. So you surveyed a lot of nurses. Was it easy to get those responses? And then how do you manage the tension between asking the workforce themselves to take action versus the organizational change? So how did you build trust, and how are you managing that tension between the work and the organization?
I can start, Patrick, and then you can follow concretely. So in general, so we have a software, and so people log in and have to register and so on. So that's available. We make it available mainly by QR codes, and so there are a lot of complaints in the hospitals. We have every hospital has a Magnet contact point, and we provide them data on response rates so that we knew exactly. So there was an exact monitoring to that. So the focus of the aim was to have at least 200 responses by hospital. I can say it's not an easy task. It's difficult in COVID times because people have other priorities. And so mainly what we see is what Patrick was also telling. So a lot of things were going on the executive level. So it means really going to the program, really making that gap analysis without any real impact yet on the workplace. And so it makes it difficult, of course, of people because they don't see the connection. So, but yeah, I think they did wonderful things in these various hospitals to really motivate people to put a survey, make it visible, and really invite people. So it was, but I think it required a lot of effort to do that. Certainly in these special circumstances of COVID, it was not an easy thing to do.
Okay, thanks. And Patrick?
I think you need persuasion. It's really important. So we have a different approach than other hospitals. So I'm the Magnet coordinator, but I'm also working bedside. So I am an APN on ICU. So and we are two Magnet coordinators who are working both bedside, and so we try to set an impulse to change on eye level. And I think that's one thing that's really important. But we are also running all over the wards every 2-3 weeks and asking them to take part in different working groups, for example. And another thing is that you have to do actions which are perceptible for nurses. And that's why we used we started with the PPM and also the mentoring program, because that are changing which are visible. And so the ppm, for example, it's hanging out on every ward. Every day when you are walking about your ward, you see something change and something you work with. And I think that's important.
Direct feedback, okay. Because is it a tension? Like, is the workforce saying, why do we have to do everything? Why can't you just hire more nurses and fix our resources? Are you seeing that, or is it actually people understand the status, the situation, and are willing to do what they can, whatever's in their reach?
Honestly, sometimes it's really hard to convince the nurses to work with us. So there's such a burden of the last 2 years, and they are tired. And we also say it's not voluntary to work on the working groups, so it's all working time. But I think at the moment many of the nurses are still waiting, and what will really change. But we see over the last 2 years that more and more nurses come to us and wants to work with us. So I think we have also to be a little bit patient. We only can step by step, and
Because
Emma's running a project. Oh, sorry, Walter, go ahead.
It's also the general aim of the Magnet program, and so it's really giving more things to say. So it means also listening to people and really trying to solve their problems, and so that they can spend more time with patients, because that's their main goal and aim. And so if you listen to that and you do that, you get a lot of support.
That's great advice and really great reflections. And in fact, Emma's leading a project called Be Well, looking at a strategy on upskilling and reskilling the workforce. And KU Leuven are one of our advisors on that project. And we feel so lucky to have the benefit of all this experience of not just the Magnet project, but all the other work you do that can help feed into this collective work on improving the working conditions and the mental health and well-being of the workforce. Walter and Patrick, I really thank you for not just being here today, but for doing this really important work. Thanks for joining us.
Thank you very much.
You're welcome.
And thanks everyone for your participation today. I've given you the link for the evaluation. If you could really please just click on that and spend a few minutes. And otherwise, I see a lot of regulars in the room. It's great to have you with us. I love that you're part of our community of practice. Next week is our next webinar on Thursday the 27th. It's with Ms. Caroline Costong, who I think many of you will know. She's the director of EuroHealthNet, and we'll be looking at empowering communities in a way towards stronger health systems through community empowerment. So hope to see you there. And I wish you all to take care, and we'll see you soon.
Bye.